Great, sounds good. And welcome everyone to the March 1st edition of the Provider Update. Thank you so much for joining, as always. I was also just was reflecting back that, I mean, we're almost at our 2-year mark from the first case of COVID in New Mexico. So just kind of a moment to take a breath and, realize all that we've been through in this 2 years. Whoops, that didn't work so well on the sharing. Let's try that again. Share screen. All right. Can everyone see my screen?
Yes, we can.
All right. And probably the other thing to reflect on is every time we say, hey, we don't think there'll be any updates next week, so we'll go to an every other week schedule, like 20 minutes later, the CDC puts out a new update, which is what happened this week. So we'll go through the updates. So again, our mission, as always, is to ensure health equity, working with partners to promote health and well-being and improve health outcomes for all New Mexicans. And obviously could not be doing that without you in normal times, and most definitely in COVID times. Oh, and I just saw that Laura joined. Do you have anything for the group, or?
Oh no, I was just joining.
Okay, good.
Yeah,
welcome.
Hi, everybody. Thank
Jump
you.
in anytime. And
Okay.
I think Dan's on the phone as well. So
Awesome.
for both of you. So
Great.
added to our ever-growing timeline is just last Tuesday, the vaccine interval changed to allow for up to 8 weeks between the first and second dose of any mRNA vaccine. And we'll talk a little bit more about that in a couple slides. And then shortly after that, the FDA did amend the Evusheld EUA with a recommendation for an increased dose. And Evusheld, again, is the long-acting monoclonal antibody, or really 2 monoclonal antibodies given to people with immune compromise as PrEP, or pre-exposure prophylaxis. The other thing that happened last week, which we will also talk about, is the text that went out to people who had self-identified as immune compromised in the app, reminding them of all the things they could do to protect themselves. And we'll talk a little bit more about that in subsequent slides. This is the community transmission slide that we have been tracking. So we can see, a little more orange peeking through the red across the country. But really the big news was that the CDC did create a new map with new metrics looking at community levels of COVID by county. So my feeling is it sounds like they may be phasing out the all red one in favor of this one. But what's interesting about this on the CDC website is really just tying some of those questions we all have about masking, and I mean, masking is probably the biggest one, to some metric. How do we decide when we should be masking and when we shouldn't? So this is how the colors are determined on the new map, and it basically still does take case counts into consideration. So we aren't completely away from case counts, but this number is fairly high. So it splits it whether you're below or above 200. On the old map, to get into the red, it's 100 doses per 100 cases per 100,000 in the past 7 days. So this is kind of a more liberal cutoff point. And if you have fewer than 200 cases, then it looks at new COVID admissions per 100,000, a 7-day total, and the percent of staffed inpatient beds occupied by COVID-19 patients. Also, this one's a 7-day average, actually. And then here's the numbers you need to hit to get to the respective colors. And then it goes through the same for 200 and more. So again, it's starting to shift the metric from just case counts and percent positivity, which we know those are becoming less accurate metrics anyway, because of so much home testing that isn't reported, as well as maybe with a less virulent variant, maybe a less important metric overall. But what we do know, is important, or what we are really working hard to avoid, is hospitals getting overwhelmed. And so that's built into this, this metric. Then
Also, sorry.
go ahead.
Sorry, no, I think also something that they had mentioned on that call, the CDC call, was also that, everything was looking red, like you were saying, like the whole state. So that it was hard to say, what are we going to do next because of a certain color? And I think that's something, as we look ahead of like living with COVID, is how do we use these metrics? Like, so for instance, let's say you are in orange, what are we going to do as a healthcare system, right? Because does that mean then, like, because DOH will no longer have that FEMA funding, in the future, where we are able to pay for a lot of testing, right? And so, like, what does this look like for the healthcare system to say, hey, we're high, do all of our, healthcare systems start ramping up testing? What does this look like? And I just wanted to share that because, a lot of you are from healthcare systems, to be like, what does this mean for all of us as a global system in the state of New Mexico? And what do we do with this data? So just kind of a thought there on like how we can work together on this.
Right. And they did, it's sort of a perfect lead in. Let me just point out this one cute county check where you can type in your state and your county, and it gives you what color you are if you can't find your county on the map. And then this is sort of on a personal level, what you might want to do if you live in a low, medium, or high risk county. But what Laura's talking about here is they also attached it to community level prevention strategies as recommended by state and local authorities. And it was too long to clip the whole thing. So this is probably the least interesting, the low metric. But it goes through medium and high, and things like ramping up testing or instituting asymptomatic screening in workplaces. So I think it is starting to get to exactly what Laura's talking about, sort of a plan to be able to ebb and flow with as COVID ebbs and flows. Yeah, anything more on this? Anyway.
Yeah, sorry, maybe a little bit more, just like, yeah, and so maybe like, how are we as a provider community then being able to access those, those medications and treatments more quickly, just thinking about our whole system as a whole. Yeah, and I know some people have had some difficulties maybe getting some access, especially patients that have difficulty with transportation or getting to providers. So how are we helping that group of people? So just thoughts on how we can improve together.
And one last thing I will say about these metrics, it does have the little disclaimer, it may not apply to healthcare settings such as hospitals or long-term care facilities, because I think really the recommendation still stands at this point for at least inpatient hospitals and long-term care facilities to continue masking and really, following the kind of the most conservative guidelines. And I think a lot of us in outpatient medicine have followed suit. Just an update on BA2. And again, I forgot to check this morning. It does update every Tuesday. So this is from last Tuesday. But it hadn't changed a lot. It's about 2 to 6% of cases per the CDC nowcast. So the pink pieces of the pie are the percentage of BA2 cases. And just a reminder that the BA2, while closely, well, not that closely, but somewhat closely linked and related to Omicron, does not have that S gene target failure, which made the Omicron we're dealing with now easy to identify on some of our testing. So it really is more genomics sequencing that we're identifying. So we'll continue to track that. This is New Mexico specific data, just, cases plummeting, which is awesome. And also our infection rate plummeting, which is also great, and really the lowest it's been the whole pandemic. And just following along on hospitalized patients, they are also going down, but as we know, a lagging indicator, so often takes a little bit longer for hospitalizations to normalize, but it's definitely getting better. This is from the New York Times tracker, splitting out admissions by age group, and not too much different than last week, although this was sort of an intriguing little uptick, which, one of the points about hospital admissions is like sometimes they get reported in batches, so it's not always the most like smoothly linear metric, but something to watch out for. But also, again, the point that over 70 is just absolutely the highest risk and has been through the whole pandemic, or higher age. These are our vaccines for all of you that are out there giving vaccines. It's a battle for each one. We basically are down to around 15,000 a week from our last peak here of 85,000 a week across the state. So that's hard to see, but good. Thank you to everyone who just continues to plug away one vaccine at a time on this. This is our statewide vaccine progress for 5+. Again, just slowly ticks up every week. So this is taking everyone who's eligible for a vaccine, their first dose, and a completed primary series. Okay, on the vaccine updates, we had our vaccine watch list, and this one actually came to pass. The mRNA dosing interval, ACIP was looking at that 8 weeks between dose 1 and 2 of mRNA vaccines, and indeed put out kind of a this may be a good thing to do kind of recommendation, not super definitive. And I just want to, while we're on this, the 4th doses, the debate continues. We certainly have heard nothing about a 4th dose, except for in the setting of immune compromised people, which we will talk about later. But there's been otherwise no updates that I'm aware of on any of these other things that we have on the vaccine watch list. So the vaccination schedule, again, this is on the interim clinical considerations page, but it basically just says for that 2nd dose, you can dose it anywhere between 3 and 8 weeks after the 1st dose. And the reason to do this was twofold. One is it may actually help with the immune response, and the second is it may decrease the already small risk, but the risk nonetheless of myocarditis and pericarditis, which, as we know, the group of men 12 to 39 are highest risk for that. So the people that it's not recommended for, it's not recommended under 12. They said no data. It's not recommended for people over 64. Over 64. Again, I think with the idea that it's a relatively high risk and potential, I shouldn't use the word immunocompromised, but a high risk group. And then anyone else who needs rapid protection due to increased concern about community transmission or risk of severe disease should also, they say, continue on the fast path to getting vaccinated. And then anyone who's immune compromised. So really it's just sort of one more thing. We've talked a little bit about shifting from kind of that mass vax model where you barely talk to anyone, just get that shot in the arm and off they go, to kind of a little bit more. There's just every new recommendation brings with it like a little more nuance in talking to patients about what would be best for them. But I think, the bottom line here is the original intervals we have still work, they're still safe, and they're still what's in the EUA. But in certain circumstances, you may want to consider moving that interval out. And certainly no one should feel bad if they didn't come back for 8 weeks, because maybe they made a good decision, like if they just forgot. This is some of the studies that, I don't know, there's a CDC COCA call, and they presented some of the studies that they presented to the ACIP. And it's kind of a lot to look at, but I liked this one is about the myocarditis and pericarditis. It's a rather large study out of Canada. And just looking here at the intervals, so if you get a Pfizer followed by a Pfizer, and there were a fair number of patients in this arm, the 235, almost 236,000. But if you go to 8 weeks here, you're getting, if you have 2 Pfizers with an 8-week interval, like really, a much lower risk of myocarditis and pericarditis. Same happened with Moderna. And part of the take home here, which, I think we've heard before, but that Moderna does come with a slightly higher risk than Pfizer in the first place, but that risk is lowered by waiting 8 weeks. And then here's a Pfizer followed by Moderna. And interestingly, they said there really weren't any that started with Moderna and that got Pfizer. But also interestingly, this came along with it just a higher risk in general. So anyway, there are lots of studies out there, and I'm just sharing this as the one that was presented to us as sort of, evidence for making this decision. This one, same thing from the CDC, and it is really more talking about vaccine efficacy against infection and then against hospitalization. Here are the timeframes here at the bottom, and really kind of showing that at 7 to 8 weeks, you do look like you get a bump in efficacy for both against infection and hospitalization, and that waiting longer than 11 weeks really doesn't help. So, and that same over here, which is, these are just 2 different areas, British Columbia and Quebec. Okay. Then on the flip side of that, and this is Dr. Sosa on the ECHO yesterday, what presented a study that actually didn't really show that there was a lot of significance in waiting a longer interval. And really, I just sort of present this to say, the jury may still be out, but it does look like the evidence is leaning towards perhaps having a longer interval between them. And it looks like, I haven't heard of any studies that show a higher risk of myocarditis if you wait longer. So that in itself may be just a good argument for trying to space out that interval. This just showed no difference in interval, but it was a set of healthcare workers, and there are some things about healthcare workers that maybe are not generalizable to the rest of the population. And they did acknowledge in their study that this was in contrast to other studies that had showed differently. This our amazing vaccine team, and thank you to Edward Wake, but at some point quite a while ago, people were looking for one graphic that pulled everything in, and so Edward keeps updating this one, sort of becoming more like wallpaper than a handout, but he did it. They did it and got all the current recommendations onto one page. And so anyway, we can send that out as a PDF if helpful. On to the immune compromised. Just a reminder, people with immune compromise do get 4 doses, so 2 doses of a primary series, a 3rd primary dose that sometimes gets called an additional dose as well, but really starting to talk about it as a 3-dose primary series, and then followed by a booster dose now at 3 months. So this is basically, we know that this did create some havoc out there, but a text was sent out to everyone who indicated that they were immune compromised in the RTS system. This is the text that actually went out, and it really more was meant to inform people that there were some choices. It directed them to this new toolkit that Dr. Perahone put together on the website of sort of all the things people could do who are immunocompromised, all of the things they could do to protect themselves. But obviously it did then kind of cause a lot of people to seek a 4th dose who maybe didn't technically meet the immune compromised definition that the CDC has tied to that 4-dose 4-dose regimen. This is just the link to the toolkit, and has some good, it's really set up for patients to be able to go and learn about the vaccine, the Evusheld testing and masking. This is again just the list, which is fairly strict, of moderately to severely immunocompromised people who are both eligible for Evusheld and that 4-dose vaccine regimen. But on the other hand, the CDC says people can self-attest to their moderately or severely immunocompromised status. And I think that is in the end the approach we took, which was, certainly if people had questions, we wanted to answer them. But if people were checked off that they were immune compromised and really wanted that 4th dose, we move forward with it. It seems to be the approach that many have taken. And then there's also this caveat that on a case-by-case basis, providers may talk with patients and make a decision about timing that's different than what's standard practice. This is just the updates again on mostly that moving the booster for immunocompromised people to 3 months. I think this is the last update I have, which is people with certain medical conditions got updated. It's not a page I've really looked at all that much recently, but these are does list all the medical conditions and all the evidence that they actually put people at higher risk. And they added 3, which is additional disabilities, primary immunodeficiency, which didn't seem that surprising, and physical inactivity, which mostly just, was the pause for me that physical inactivity is probably yet another kind of side effect of this 2 years that we've all spent. So with the nice weather, maybe in lower cases, get all of us to get moving and to kind of nudge our patients to get moving. With disabilities, I think it's interesting that really they may have added a few more, but the main was people with any type of disability that makes it more difficult to do certain activities or interact with the world around them, including people who need help with self-care or daily activities. So just kind of a broad, like anyone for whom this pandemic has made things harder. Excuse me. And then here's all the links. There's a couple provider facing links and one for the public on these conditions. And then these are from those links, just looking again at the relative risk for bad outcomes from COVID, and just again, kind of this stunning look at the risk that age confers with COVID. And then here's for medical conditions. And then the next one, I think, just goes by how many comorbidities. But even if you have greater than 10 comorbidities at 3.8, you're and you're young, your risk is still much less than someone who's 65 and over. All right. Oh, sorry. One more, Evusheld dosing. So the FDA did increase the initial authorized dose of Evusheld to 300 milligrams of each of the monoclonal antibodies. It is 2 shots given consecutively. So those will both be now rather large 3 ml shots. So probably go for the gluteus on that. And it actually said that if you have given it to a patient, if you gave the lower dose to a patient, those patients should be contacted and told to come back in for an additional 150 milligrams, which was the original dosing. The reason for this is just some studies that showed that the higher dose was probably more effective against Omicron and other circulating variants, they said. Let's see, I thought there was one other thing about Evusheld. They did actually, initially they said that it would be redosed every 6 months for people with immune compromised. And they actually kind of took that off and said, we're not sure, we'll get back to you. So it may be actually a shorter interval is needed, especially, if Omicron remains the circulating variant. So just a heads up on that. And then, and again, this is just a reminder that the website does now, you can search by, I know this is hard to see, but the therapeutic that you are looking for, either as a patient or as a provider, and then it will show whether it's available, all the pharmacies at which it's available at, and we'll say no if the pharmacy is currently out of it. That gets updated every week, every day by our pharmacy team, our amazing pharmacy team. All right, and I think we talked about the mask mandate last time. I don't think anything's changed there. A quick reminder about the Better Together New Mexico grant program. If you're working with any, it doesn't even have to be nonprofits, but community organizations who may be looking to help with vaccine in their community, and the contact information is there. And that is it. All right, thank you so much. And then do we have any questions? Let me go to the chat here.
Dr. Darwin asked a question about the border, like if you had a high transmission next to low community transmission. So I just mentioned that, you know, that's kind of been the whole time when we had the red, yellow, green, turquoise framework has been problematic in terms of like, what if you're right next door to each other? So I just kind of like asked, like, had anyone had thoughts about that? Or, you know, I think it's meant to be as guidance, and also like just to let, you know, hospital systems or clinic systems know, like, hey, you know, you might be getting a bunch more people coming through. I know that we're looking at that for wastewater surveillance as well. You can tell 2 weeks before you can potentially have a surge that you potentially could be seeing more COVID, but I don't know, like, would love to hear what other people think about the border states, you know, border counties. If anyone has thoughts on that.
Yeah, and I mean, the wastewater, it's actually a topic I keep meaning to, you know, to some extent, I know it's happening in New Mexico on some level. We were part of an early pilot about wastewater, but don't really know that much about it. But I think it is a really interesting surveillance tool. And anyway, I don't know if I keep meaning to find out more about it to bring to this call, but the CDC does have a map of every place that's doing wastewater surveillance.
Yeah, and if people are interested, we could have someone from our team that's doing the wastewater surveillance. It's not in every area in New Mexico, and like there was an initial pilot, but it is a kind of an area that's growing potentially, because you can see it for other illnesses, not just COVID. So it is a kind of a future idea, and our state lab is getting ramped up to actually build that, to have that capacity in the future. So kind of a more of a future thing.
Yeah. And
cool.
Let's see. I think I was just going to give my 2 cents on the sort of county by county thing. I think it is nice to see the counties starting to get to lower levels of transmission, but it does seem like, you know, it's probably not necessarily, especially in the healthcare setting, decisions to be made on a purely county level, because as we're pointing out on this call, there's lots of, you know, there's lots of movement across county borders. So yeah, and I think, I mean, it'll be interesting to see. I think it was a good and interesting move to sort of tie some behaviors to metrics and changing those metrics a little bit from just case counts and percent positivity. But I imagine it's something that will, you know, evolve a little bit over time. Yeah, that will continue to evolve. Okay, and then there was a, well, and then the other thing I think Laura's pointing out is just how, you know, in counties with small populations, a couple cases can kind of, you know, at least on our old red, yellow, green, turquoise, could really change dramatically what color. I think this is a little bit like most things are sort of averaged over 7 days. Someone did ask a good question about what if you don't have a hospital in your county, and I think it is the probably yeah, I guess I'm not exactly sure like what the scope of hospitals they're looking at. So a good question to find out about. But I think hopefully these metrics are a little bit less just kind of zing-zanging back and forth from one week to the next. Let's see, with new updates on interval time, would any individuals have to restart their primary series if they waited too long between first and second dose? And yeah, I think this is a great question. So no, you never, at least right now, never say never, but right now you do not ever have to restart a series. So even if you've waited like, 3 or 4 months, just pick up where you left off. And that's even with the new guidance. The flip side of that is a lot of people, well, I don't know that a lot of people will ask, but if people are wondering, oh shoot, I got my Pfizer 3 weeks apart, do I need another one just because I got it too close together? And the answer is no on that. The only time you'd have to repeat it is if you got it closer than that 4-day grace period. So for Pfizer, you can get it, your second dose, 4 days shy of 3 weeks. For Moderna, you can get that second dose 4 days shy of 4 weeks. And if you do get it closer than that, let's say you get your Pfizer 2 weeks after the first one, that dose is supposed to be repeated. All right. And then, okay, a call for a little more information on wastewater. So we'll try and track that down for the next call. And I think that is something that's kind of sat in, I don't know, Laura, like the environment department and kind of EPI, not so much a Department of Health thing, or at least I haven't been so involved in it, but I think it is super interesting.
So yeah, I can get the person from environment department to talk about the pilot, and then that has transferred to our EPI department, but they're just starting to ramp it up. So we can have like kind of a more of a discussion too about like what people would like to see in it, as they're ramping up.
Yeah.
Yeah. And
All
then
right.
what has already been done.
Yeah, that would be great if we could get someone who really knows what they're talking about on. So on the scheduling, so I'm glad, Rachel, thank you for bringing this up, which is like one of the things about the app that we have all loved is that it automatically schedules people back into that second dose if you have appointments open. And so I think at the end here, when we get through the questions, maybe we'll have a little discussion about how best to kind of accommodate these new new recommendations with scheduling. On the question of men and women, the CDC does call out men 12 to 39 as the highest risk group. So maybe for myocarditis and pericarditis, so maybe the group you really do want to recommend that longer interval. Women aren't, it's not 0 for women on the myocarditis and pericarditis, but much more of a risk for men. So yeah, so it is hard to kind of set absolute rules. Again, maybe as case counts come down, you want to push people a little bit more to a longer interval, in that maybe there isn't quite so much urgency to get fully vaccinated. And it's a relatively small group at this point who haven't started down that road of vaccination at all. But it's actually somewhere between 1,000 and 1,500, maybe as much as 2,000 some weeks. So it was higher than I had thought of people that are still getting the primary series. And certainly if someone is about to start a job at, the West Side Shelter or someplace where maybe risk is higher, or like in a detention center or a long-term care facility, like those would be settings where you would probably just recommend go ahead and get the vaccine as quickly as possible. Let's see, the call center has been scheduling people who do not meet immunocompromising conditions. They are not happy when they get to a vaccine site. The people are saying they went over medical history with call center. So haven't had a chance to answer that one. And we definitely, I mean, we do know that the call center has protocols. They do review medical histories and, you know, should be on the same page, although, you know, it is certainly possible that they get it wrong. I think sometimes they are probably in the same situation that lots of us are at vaccine sites where people are just really insistent, and yeah, and that makes it hard. So we can definitely take that feedback back to the call center, but all I can say is that they are working off the same list that we are.
Well, Miranda, may
Yeah.
I jump in on that? This is
Sure,
Dan.
sure.
Yeah,
Thank
I mean, I
you.
think we sort of have two guidances from CDC. One is that relatively narrow list of conditions that qualify as immune compromised. And the other is to really say that patients can be self-attested for immune compromise. So I think the bottom line is that if a patient has checked off the box in the app or on their you know, paperwork saying, you know, I'm immune compromised, you know, we have enough doses, there's no harm to it. And even if they don't meet those strict criteria, you know, they are self-attesting as immune compromised, and, you know, it's a good idea to just give them the dose. So I know that's a little ambiguous, but there it is.
This is Tanya. Thank you, Dan. And I sat and worked with people to make sure they could get what they needed. But I had a person call me that I'm a diabetic, and the call center scheduled me. We finally went through, and they actually had some immune compromising conditions that they didn't even realize were immune compromising. They just think the general public focuses on the outcome list. They look at, I'm overweight, I'm diabetic, and I have high blood pressure. And then I went through and I'm like, but you're on methotrexate for your rheumatoid arthritis, but that's not immune compromising. So a lot of them we did get, you know, work through, but thank you for what you just said.
Awesome. All right. And then Karen has a question. I don't know if anyone from vaccine program is on, but different shippers and loggers coming from Pfizer with different light system, any updates? That is not something I can answer. And I don't know, is Edward on? So Karen, is there, yeah, let me ask Joelle, and then is there something specific just about like?
Yeah, well, we got, can you hear me?
Yes.
Yeah, so we got a couple of shipments today, and it sounds like I'm not at those sites, but it sounds like instead of the 3 different options for blinking lights, now there's 2. And what Pfizer is sending is a bit different too. And so they get like right away an email that says, don't use this vaccine until, you know, you've gotten clarification. So I don't know, things have been going so smoothly, and then today was just kind of like a shock. So I just didn't know if anybody knew anything different. We're having now to hook up to a website and try to upload the data from the logger to the website and send to Pfizer. So
Shoot, and I'm just
Hey, Karen.
realizing, I think Joelle is off. Oh, Edward, do
Hey,
you
Karen,
know
this
about
is
that?
Edward. I just put my email in the chat.
Okay,
Get in touch with me after the meeting and we can figure out what's going on.
okay, thank you.
Sure.
thank you. All right, and the dose for the 4th vaccine, again, for Pfizer, it's the same dose. So really the dose for the 4th vaccine is going to be whatever dose you use for a booster in someone who's not immunocompromised. It's really the booster dose. So full dose Pfizer, full dose Janssen, half dose
Thank you.
Moderna. And then that third primary dose or additional dose is the full dose Moderna, and obviously full dose of the others. And then just to say it one more time, because this is the most confusing situation, I think, and the one that we did ask CDC about, but there are people who got a 2-dose primary series and then a booster, not knowing about the immune compromised recommendation to have a full additional dose. So when they come for that 4th dose, now they haven't followed the usual schedule. So the guidance we got from CDC was to treat that half dose then as just a mistake and go ahead and give a full dose at that time and kind of pick up from there. Which does mean that someone might end up with 5 doses. But I think another option is, especially for people who maybe aren't in that severely immunocompromised group, to some extent give them the full dose and call it good at those 4 doses. They've gotten 3 full ones and 1 half one, but that's unofficial. Just sort of my thought about it. And Dr. Darwin, data loggers, we would love you to chime in.
Hi, good afternoon. Can you hear me?
Yep.
All right, so just a little bit about the Pfizer's data loggers. Most of my sites have received the new shipping container. It's reformatted, it's improved, better technology. It's called a control saga logger. So the look and feel of it is a lot different from what we're used to. It was launched last week. Some enhancements that goes along with this new updated technology with the data logger includes location accuracy, specifically related to cellular network, because that's how it communicates from a GPS standpoint here. It also has improved data transmission capability. Also, the look of the panel, the LCD display is reconfigured. It has a lot more intuitive visual point visual site metrics, like related to the minimum, the maximum, temperature, visibility, the battery life display. Obviously, when this is received, it should be returned back to the Pfizer shipping with with the enclosed shipping label there. But basically, it does have a start and stop button, and there's some specific and now I guess more directions at the Pfizer at the website, Pfizer website there, to kind of get more understanding of this new control it saga logger. So I just want to share that with the group. But thank you.
Great, thank you. All right, are there any other? Oh, Rachel has another question. Now that we are in March, would it be possible to go back to more COVID-related questions on the questionnaire rather than flu-related on the app? And I think that is a good thing to be thinking about, but probably not quite there yet, is my guess. But we definitely a question we can take to the immunization program. Probably still hoping to get a few more flu shots in before we call it quits for the year. All right, are there any other questions? And Chris Schroeder, do you have anything for the group?
Yep, I was just gonna jump on. Folks that are using the app, Thursday, we will be having a meeting because we are changing some of the flow in the actual documentation portion of the app. So I encourage you to be there. We'll send out instructions beforehand as well. Essentially, when administering the vaccine, we're going to basically ask which vaccine was it? Was it Pfizer for kids, Pfizer, and then Moderna, whatever it may be, and then filter the lots based upon the vaccine type, just to minimize any documentation errors. But we'll review with you all that on Thursday.
Great. And that may be a better forum too, to just talk about the issues of scheduling in the app and, you know, sort of dumping people into the next, or automatically scheduling it 3 or 4 weeks rather than, you know, allowing for some choice, and kind of how to accommodate that in the app.
Yes, there should be some discussion around especially the kiddos, as the vaccine is approved for 6 months and older. When that comes, we want to make sure that it's easy to get them back for a second dose, if a third dose is necessary, how to get them back. So there's a couple of different things that we've talked through, but we want to make sure that it works for you all before we implement the changes. So we'll also be discussing that on Thursday.
All right. Well, great. If last call for questions. And if none, thank you so much, as always, for joining us for your lunch on Tuesday. And we will talk to you soon. So actually we are, and I know I've said this every week, but I think we are going to schedule the next one 2 weeks from now. But we'll send out a clarifying invite. And thank you so much for joining.
Bye, everybody. We'll talk to you all soon.
Bye-bye.